So, without wasting much more time, I would like to request our first speaker, Dr. Vishal Kishore, who is a prolific vitreoretinal surgeon, and he is the director of Vision Eye Care and Laser Center in Patna. He'll be talking to us on optics of indirect ophthalmoscopy and the applications. When do we use it? So, on to you, Dr. Vishal.
Thank you, Pooja ma'am, for the talk. So, good afternoon. I won't waste much of my time. I love everyone's time. So, coming to a talk on parts and optic principles of indirect ophthalmoscope. Now, this is a picture. This is the headgear. We can divide into the part headgear, which fits on a head, and the illumination part. We'll deal this in later slides. Now, coming to a brief history. This was first introduced by Nagel in 1864, and in indirect ophthalmoscopy, basically we make the eye highly myopic by placing a high convex lens in front of the eyes, so that a real inverted and laterally reversed image is formed close to the principal focus of the lens, that is between the lens and the observer. And this technique is called indirect because we are seeing the fundus indirectly through a condensing lens. So this is a brief introduction. So, and the principles which we follow, this Gullstrand principle is very important. Because of this, we are seeing the fundus, and the way you have to stretch your back, you have to keep your arm completely straight. This is because our whole technique follows this Gullstrand principle. So what is this Gullstrand principle? This says that the illuminating and the viewing beams must be totally separated throughout their pathway in cornea, pupillary aperture and lens. This is to avoid reflection, but they must coincide on the retina for the fundus viewing. So this principle is used in our technique. Then comes how we gain this binocularity. The binocularity is achieved by reducing the observer IPD, interpupillary distance, from about 60 millimeter to approximately 15 millimeter by the use of this prism and mirror. This is the picture where we have used this prism and mirror, and we have reduced this IPD to around approximately 15 millimeter. So this gives a binocularity. This is the indirect ophthalmoscopy which we are talking. This is the headgear. This is the illuminating system. We'll divide into two parts. One is the headgear, which fits on our head, and this is the illuminating part. What are the advantages of indirect ophthalmoscopy? This gives stereopsis, large field of view, bright illumination, minimal peripheral view distortion, complete peripheral access with scleral indentation, and there's independence from patient refractive error or moderate media opacification. Now, this is a 20 diopter lens which we commonly use in our IO, and this this painted part should be facing the patient eye. It should be away from us. This is important. And what I was telling, that Gullstrand principle. This is used before when you focus it. You focus this lens, and this lens should be, we'll be discussing the whole technique later. It should be held within your index and the thumb, and you should move your lens with this movement only. And other three fingers are used to fix your hand over the patient eye and to just open it. These two fingers are used for the movement of the lens. This is important. And after this, you have to backstretch so that your illuminating beam doesn't coincide in these pupillary aperture when they crosses cornea, lens, and they coincide directly on this retina. So for that, you have to properly focus. You have to stretch your hand. You have to bend backward. This is important to follow Gullstrand principle. Now, various lenses are used: 14 diopter, 20 diopter, 30 diopter. It is like commonly we use 20 diopter, and the diopter of this is inversely proportional to magnification. Like with 14 diopter, we have 3.8 magnification. With 20 diopter, we have 3 times magnification. Now, coming to the parts. This is in the headgear, this is the illuminating part. It has one part which controls the different size of the illuminating beam. In case of mid-dilated pupil, we can have either this one or this one. In undilated pupil, we have this option. And in fully dilated, we can go for this. Then once you fix the headgear, this is the knob which moves this illuminating part back and forth, by front and back, and you can fix at your convenient distance. This is the knob. Then just to set your IPD, you have this sliding knob here. With this, you can adjust your IPD. These two sliding knob just below this illumination part. And when you start using this, first you have to focus this either on a finger or on a blank wall, so that you can see that your IPD is proper. You are getting in both the eyes, you are seeing it properly, and the beam, the circular beam is there. And if the beam is not proper, you have this knob which you can move up and down just to set your beam direction as per your desire. And now again, on the other side, you have knob which controls the different color of the beam. It could be yellow, which we commonly use. This is the knob to switch on and switch off. This knob. If it is wireless, you have this battery charger which is attached. And this is the knob which I was talking. This is, you can have other filter. With this you can switch on the filter. This I had talked earlier. These are the different beams. So what is the indication? Thorough examination of routine thorough ocular examination, visual symptoms of flashes, floaters. If the patient have any peripheral vision loss, history of blunt trauma is there, then we do IO to rule out any dialysis or any break or any lesion which needs treatment. Or in case of previous retinal diseases, diabetic, significant vascular diseases, metastatic carcinoma. Thank you for patient hearing.